You know how we often talk about those slow, hidden dangers to our health? Well, imagine something lurking inside your arteries, not just clogging them, but actually infecting them.
That's a really vivid way to put it, and yeah, it perfectly sets up what we're diving into today.
Okay.
Infected arterial aneurysms.
Okay, infected arterial aneurysms.
Hmm.
Now, we know an aneurysm is like a weak spot, a bulge in an artery wall, right? Like a bubble on a tire.
Exactly, that's the aneurysm part.
But the infected part, how does that happen? How does an infection get in there?
Well, that's the critical addition. It's when microorganisms, mostly bacteria, but sometimes fungi or other things, get into that already weakened arterial wall. So it's not just the bulge, it's an active infection on top of the structural problem.
Got it. And for this deep dive, we're really going deep, aren't we? We're using chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the latest 10th edition.
That's right. We're tapping directly into the definitive expert knowledge in vascular surgery. Think of it as getting the inside scoop from the top minds.
So our mission today is basically to cut through all the dense medical language and pull out the key stuff for you listening, what these things are, how they start, and crucially, how doctors fight back.
Precisely. We want to make sense of how these infections happen and how they're managed.
So this isn't exactly a brand new problem, is it? Doctors have known about this for a
Oh,
while.
yeah, for a long time. The first really detailed descriptions go way back to 1885. A very famous physician, William Osler, he made the connect.
Osler, right. What did he find?
He linked aneurysms happening out in the limbs, the peripheral arteries, to endocarditis, that infection inside the heart. And he actually coined the term mikotic aneurysm.
Mikotic. That sounds fungal, like mushrooms.
It does, yeah. And that's the problem. He apparently used the term because the shape of these aneurysms, often sort of irregular and sac-like, reminded him of a fungus or mushroom.
Ah.
But it led to a lot of confusion later on because people naturally thought it meant only fungal infections caused them, which just isn't true.
So mikotic is kind of a misleading term now.
It really is. Many people try to avoid it now, or at least clarify it, because, yeah, most of these are bacterial, not fungal.
Okay, so Osler made the first connection, but it wasn't the whole story. Who else helped figure this out?
Well, a bit later, in 1923, Stengel and Wolfert showed that it wasn't just endocarditis. They found infected aneurysms could come from other bloodstream infections, too.
Right, not just from the heart.
Exactly. Then, fast forward to 1959, Somerville pointed out another key source, infections popping up in aneurysms that were already there because of atherosclerosis, hardening of the arteries.
So plaque buildup, creating a weak spot that then gets infected.
Precisely. And more recently, we've seen these post-traumatic infected pseudoaneurysms. These can happen after injuries, including IV drug use, which is a growing concern, and even sometimes after medical procedures involving artery access.
It feels like the picture keeps getting more complicated, and you mentioned we're actually seeing more of these cases nowadays.
Yes, unfortunately, the incidence seems to be rising. And if you think about it, it kind of makes sense with other trends. We have more people with weakened immune systems.
Like transplant patients or people with HIV.
Exactly. Transplant recipients, HIV, people on long-term steroids or chemotherapy. Plus, we do more invasive procedures now, and then there's the ongoing issue of illicit drug use.
Yeah.
All these factors likely contribute.
Okay, that gives us the history and sort of the context. So how exactly do these infections actually take hold in an artery? What are the main pathways?
Generally, we think about it in four main ways, based on how the infection starts. The first is called microbial arteritis.
Microbial arteritis, okay.
This is where bacteria that are just circulating in the blood, maybe from some other infection somewhere else, not necessarily the heart. They find a spot in an artery that's already a bit damaged. Maybe it has some atherosclerosis or even a congenital issue.
And they just set up shop there.
Kind of, yeah. They settle in the artery wall. And the aorta, being the biggest artery and often having plaque, is a really common site for this type of infection.
Does having other health problems make you more vulnerable to this?
Absolutely. Certain conditions definitely increase the risk. Things like diabetes, cirrhosis of the liver, needing hemodialysis for kidney failure,
Okay.
being an organ transplant patient on immunosuppressants, having HIV, chronic alcoholism, even long-term steroid use or cancer chemotherapy. All these can make someone more susceptible to microbial arteritis.
Wow, that's quite a list. Okay, so that's pathway number one. What's the second?
The second is what we mentioned briefly, post-traumatic infected pseudoaneurysms. Here, bacteria get introduced directly into the artery wall because of some kind of trauma.
Like a direct injury.
Right. Could be an accident or, concerningly, from intentional injection into an artery during illicit drug use. And it can also happen rarely as a complication of procedures where we access arteries, like for heart caths or other endovascular work, sometimes even related to the devices used to close the puncture site.
So even a planned medical procedure carries a tiny risk.
It's a small risk, yes, but it's recognized. The common femoral artery down in the groin is the most frequent spot for these post-traumatic ones. The link to drug use is particularly worrying, though, because it often involves really nasty resistant bacteria.
Yeah, that sounds bad. Okay, 2 pathways down. What is the third way these infections start?
The third is infection of a pre-existing atherosclerotic aneurysm. So you already have an aneurysm, that bulge caused by plaque buildup, and then bacteria circulating in the blood find it and infect it.
So the weak spot becomes a target.
Exactly. The diseased inner lining, or often the blood clot, the thrombus that forms inside the aneurysm, can be like a good place for bacteria to latch onto and grow.
And I think I read somewhere that they've even found bacteria inside the clots of aneurysms that weren't obviously infected. Is that right?
You're absolutely right. It's quite fascinating. Studies have found bacteria just sitting in the thrombus in maybe up to 4% of routine asymptomatic degenerative aneurysms.
Wait.
And here's where it gets really interesting. There's some evidence suggesting that maybe those aneurysms with bacteria in the clot are more likely to rupture. They found more positive bacterial cultures in ruptured aneurysms compared to stable ones.
So the bacteria might be playing a role in rupture.
It's possible. And there's even research looking into whether having multiple types of bacteria in the aortic wall might actually help drive the formation and growth of regular degenerative aneurysms in the first place.
Wow. So infection might not just complicate an aneurysm. It might be part of what causes it or makes it worse. That's a big deal.
It's a really active area of investigation.
Hmm.
It could change how we think about aneurysm development.
Okay, so that's 3 pathways. What's the fourth and final one?
The last one takes us back to Osler's original idea. Septic emboli. These are infected clots usually breaking off from an infected heart valve, like an endocarditis.
A heart infection connection?
Right. This is less common now, maybe less than 10% of cases overall. But these infected emboli travel through the bloodstream and get stuck in arteries downstream. They can lodge in the main artery channel or even in the tiny vessels that feed the artery wall itself, the vasa vasorum.
And that causes the aneurysm.
It leads to rapid infection and weakening of the wall, causing those characteristic saccular mushroom-shaped aneurysms Osler described. And these can pop up in multiple places at once. Aorta, brain, visceral arteries, leg arteries, multifocal.
4 different ways these things can start. Okay, so when an artery does get infected, what kind of bugs are we usually talking about? Who are the main culprits?
Well, it really varies. It depends on, which type of infected aneurysm it is, the patient themselves, their immune status, where they live, if they've traveled, and what caused it in the first place. The list of possible organisms is actually pretty broad.
But are there common ones?
Oh, definitely. Staphylococcus species are number 1. Very common. And unfortunately, that often includes MRSA, the methicillin-resistant Staph aureus.
MRSA. Yeah, that's always tough.
It is. After Staph, Salmonella is often the next most frequent.
Salmonella. The food poisoning bacteria. Why is that showing up in arteries?
It's a really interesting point. Salmonella seems to have this predilection, this preference for diseased aortas. It's found a lot in infected pre-existing aneurysms and even just in infected sections of atherosclerotic aorta that haven't fully bulged out yet.
Huh. Weird.
Specifically, it's usually Salmonella enterica. Something about that diseased artery wall just seems to attract it or allow it to stick.
Okay, so staph, including MRSA and Salmonella, are the big 2. What else?
Streptococcus species are seen less often now than they were before we had good antibiotics. And it's really important to remember blood cultures are helpful if they're positive. But a negative blood culture doesn't mean there's no infection.
Right, you can't rule it out just based on that.
Not at all. Getting samples of the tissue or fluid right from the site during surgery is absolutely essential for figuring out exactly what bug you're dealing with, especially if the patient already got some antibiotics, which can make the blood cultures negative.
And what about infections related to grafts or stents put in previously?
That's another growing area of concern, yes. With more endovascular procedures being done, we are seeing infections related to these implanted devices, and sometimes microbial arteritis linked to them.
You mentioned earlier that some types of bacteria are more aggressive than others, like gram-negatives.
Yeah, that's generally true. Organisms like Pseudomonas aeruginosa, gram-negative, they can produce some really potent enzymes, things that basically dissolve the artery wall components.
Yikes.
Yeah, so they can cause faster destruction, higher risk of rupture, higher mortality. They're also notorious for causing problems with synthetic grafts used for repair, like breakdown or bleeding issues later on.
And MRSA is a big problem just because it's hard to treat.
Exactly. Its resistance to common antibiotics makes it a major challenge. And we see it a lot, like we said, especially in infections linked to IV drug use.
What about some of the less common ones? You mentioned Clostridia.
Right, Clostridium species, particularly C. septicum, they have this nasty habit of causing really aggressive aortic infections. And interestingly, these are often linked to underlying cancers, especially in the GI tract or blood cancers.
How does that work? How does a gut bacteria get to the aorta?
The thinking is that tiny, maybe microscopic perforations in the gut lining might allow the bacteria to escape into the bloodstream and then find their way to the aorta, especially if there's already some subtle damage or plaque there. These Clostridia infections are bad news. Very poor prognosis if not caught and treated aggressively right away.
Okay. And fungi. You said they're rare.
Very rare, yes.
Yes.
Usually seen in people who are already quite compromised, severe diabetes, immunosuppression. Maybe they have a systemic fungal infection already. Things like Candida, Cryptococcus, Aspergillus.
And what about infections that used to be big players but aren't so much anymore?
Good point. Syphilis, caused by Treponema pallidum, used to be a major cause of aortic aneurysms, especially in the chest. But penicillin really knocked that down. Now it's rare.
Thank goodness for penicillin.
Absolutely. And tuberculosis, TB, is another rare one now. Usually it happens if TB infects lymph nodes near an artery and then spreads directly to the vessel wall. There are even super rare cases linked to BCG, the TB vaccine relative sometimes used for bladder cancer treatment. It can cause distant arterial infections sometimes.
It's just amazing the variety of things that can cause this. So with all these possibilities, how does a doctor even start to suspect an infected aneurysm? What are the clues?
Well, the way it shows up can be really variable. It depends on where it is, how nasty the bug is, how long the infection's been brewing.
So not always obvious.
Often not. You might get general symptoms, just feeling unwell, fever, chills, classic infection signs.
Okay. Anything more specific?
Sometimes you might get pain, like back pain or abdominal pain, depending on the location. Yeah. You might see signs of little clots breaking off and causing problems downstream. That's embolization. Or you might actually feel a lump, a pulsatile mass that's tender to touch, either in the abdomen or maybe in a limb. Sometimes the skin over it looks infected too, red and swollen cellulitis.
And I guess sometimes the first sign is the worst case scenario.
Unfortunately, yes. Sometimes the very first indication is rupture. The aneurysm bursts, the patient becomes unstable, massive bleeding. It's a huge emergency.
Okay. What about lab tests? Can blood work help point towards this?
It can give hints. Often you'll see a high white blood cell count or elevated inflammatory markers like ESR and CRP.
Yeah.
But lots of things cause those to go up, so they aren't specific.
Not a slam dunk.
Not at all. Now, if you know a patient has an aneurysm and then they develop positive blood cultures, that's a huge red flag. High suspicion right there. But again, negative cultures don't rule it out, especially if they've already had antibiotics.
So it sounds like you really need pictures. Imaging must be key.
Absolutely critical. Imaging is how you diagnose it, and it's also essential for planning any surgery.
What kind of imaging?
Ultrasound or duplex ultrasound can be useful for peripheral arteries, like in the legs. But for the aorta, which is deep inside, ultrasound isn't as good. The gold standard really is CTA-computed tomography angiography.
CTA, that's a CT scan with contrast dye.
Exactly. Gives incredibly detailed pictures of the arteries.
And what are doctors looking for on that CTA scan that screams infection?
Several things. They look for the shape of the aneurysm. Is it weirdly shaped, like saccular or multi-lobed or eccentric, meaning off to one side? They look for signs of inflammation around the artery fuzzy tissue, fluid collections. A really strong sign, though less common, is seeing air bubbles within the aneurysm wall or the clot inside it. That suggests gas-producing bacteria.
Air bubbles. Wow.
Yeah, pretty definitive sign of infection. And of course, they look for signs of rupture or leaking. Sometimes, if the first scan is suspicious but not totally clear, doing another CTA a few days or a week later can be really helpful. If the aneurysm is growing rapidly or new ones are popping up, that strongly suggests infection.
Are there other scans that help?
Yes. PT scans, often combined with CTA PETA, can be very useful. Infected tissues are metabolically active, so they tend to light up on a PET scan because they take up the radioactive tracer.
Like a hotspot for infection.
Kind of, yeah. MRI and MRA, magnetic resonance imaging and angiography, are also good for seeing inflammation. There are alternatives if someone can't have the CT contrast eye or if the CTA results are a bit ambiguous. There's also a nuclear medicine scan using labeled white blood cells, but that's used more for suspected graft infections, less reliable for primary infected aneurysms, though it can sometimes add supporting evidence.
Okay, so diagnosis is puzzle symptoms, labs, but really driven by detailed imaging like CTA. Once you do suspect or confirm it, what's the plan? How do you treat this?
It's a two-pronged attack, always. You need antibiotics to fight the infection, and you need surgery to deal with the damaged artery and get rid of the source of infection.
Both are essential.
Absolutely. You start antibiotics immediately, often broad-spectrum ones at first, to cover the likely suspects.
While you're waiting for culture results.
Exactly. And you need to get those cultures, blood cultures, before antibiotics if possible, and definitely samples from the surgical site tissue fluid, the aneurysm wall itself. Once you know the specific bug and what it's sensitive to, you tailor the antibiotics.
And how long do the antibiotics continue?
For a long time. Minimum is usually 6 weeks after the surgery, but often, especially for aortic infections, it can be much longer. Months, sometimes even lifelong, depending on the bug, the location, and what kind of repair was done.
Lifelong antibiotics. Wow. Okay, what about the surgery part? What are the main goals there?
Several key goals. First, get control of the artery above and below the infected segment early on to prevent massive bleeding during the operation. Second, get those crucial samples for culture. Third, completely remove the infected part of the artery, the aneurysm itself. Fourth, debridement, clean out all the infected and dead-looking tissue around it. Really thorough cleaning.
Get rid of the whole infected zone.
Right. And finally, you have to reconstruct the artery to get blood flow going again.
How do they rebuild it? What are the options for replacing that infected piece of pipe?
There are two main strategies. You can do an in situ repair, meaning you rebuild it right there in the original spot, even though it's an infected area. Or you can do an extra anatomic bypass, where you basically reroute the blood flow around the infected zone using a graft placed in clean tissue tunnels.
Okay, let's talk about the in situ options first. What kind of materials can they use in an infected field?
For in situ, you've got a few choices. You can use the patient's own vein, harvested from somewhere else, like the leg that's called an autogenous vein graft. You can use a cryopreserved arterial allograft. That's a donated human artery that's been specially processed and frozen. Or you can use certain types of prosthetic grafts, like Dacron, that are either impregnated with silver or soaked in antibiotics like rifampin right before implantation.
Which one do they choose?
It really depends. Surgeon's experience plays a role, how sick the patient is, exactly where the infection is, and frankly, what's available. Those allografts aren't always easy to get quickly.
And I heard sometimes they wrap the new graft in other tissue. Why do they do that?
Yeah, that's a really important step for in situ repairs. After putting the new graft in, they often cover it with healthy, well-vascularized tissue like omentum, which is fatty tissue from inside the abdomen, or flaps of nearby muscle.
What does it do?
It brings a good blood supply right to the graft area, which helps fight any remaining infection, promotes healing, and helps prevent the new graft from getting infected itself. Sometimes they'll even put antibiotic-releasing beads or sponges around it temporarily.
Makes sense. Okay, you mentioned location matters a lot. Let's focus on the aorta, since that seems like the big one. How do they manage infected aneurysms in the chest versus the abdomen?
Yeah, the aorta is definitely the most challenging location. These infections can hit any part of it, from right where it leaves the heart, down through the chest, into the abdomen, all the way down to where it splits for the legs.
In surgery, there must be high risk.
It is. Very complex surgery often needed. Patients with aortic infections often have those high white counts and positive blood cultures we talked about. And the CTA usually shows that inflammation or mass around the aorta. Interestingly, sometimes the infection hits parts of the aorta that don't even have much plaque yet. But the good news is, with faster diagnosis and aggressive treatment, outcomes are getting better than they used to be.
What about specifically in the chest, the thoracic aorta?
Thoracic aortic infections are incredibly dangerous. Mortality rates are high, maybe 30 to 50%.
Wow.
Yeah. Gram-positive bugs like staph, enterococcus, strep pneumonia are common culprits there. Salmonella in the chest aorta is particularly bad news, very poor outcome usually. Symptoms can come from the aneurysm pressing on things in the chest, but often the first sign is rupture.
So what's the treatment?
Surgery is key. You have to resect, remove the infected segment, clean everything up, and then start long-term IV antibiotics.
Yeah.
Sometimes they need a spinal drain temporarily during surgery to protect the spinal cord. Access can be through the breastbone, the side of the chest, or a big incision combining chest and abdomen, depending on where the infection is.
And the reconstruction.
Usually in situ repair, most commonly using either a cryopreserved allograft or a Dacron graft soaked in rifampin. Another option sometimes is an exclusion bypass, basically bypass around the infected part, then close off the infected segment. And endovascular stent grafts, EVAR, are being used more, especially for patients too sick for open surgery, maybe as a bridge to later surgery or just for palliation. But trying to treat these with just antibiotics, very high mortality, doesn't usually work.
Okay, what about the abdominal aorta? That's where most typical aneurysms happen, right?
Right. Abdominal aortic infections are more common than thoracic. Again, the surgery depends on exactly where it is, how extensive, and the patient's overall health. Infections starting in a previously normal aorta often happen higher up, near the kidney arteries. Infected pre-existing aneurysms are usually lower down, below the kidney arteries, infrenal.
Are some locations harder than others?
Oh yeah, the ones right around the kidney and gut arteries, perirenal, perivisceral, those are technically very demanding. For those, in situ repair is usually preferred because you need to keep blood flowing to those vital organs. Surgical mortality overall for infected abdominal aortic aneurysms is still significant, maybe 15 to 38%.
And the repair options are similar. In situ, mostly.
In situ is definitely more common now than extra anatomic bypass was in the past. The options are the same ones we discussed: cryopreserved allograft, antibiotic-treated Dacron, or that technique using the patient's own leg vein, the NAI's neo-aortoiliac system.
NAIs. Tell me more about that.
All right, we mentioned these graft options. Let's break them down a bit. The cryopreserved allografts, the donor arteries, they're really good because they seem quite resistant to getting reinfected, especially by those nasty gram-negative bacteria.
So they hold up well in an infected area.
They seem to, yes. Surgically, they handle nicely, feel like a normal artery. The downsides are cost, they're expensive, and availability. You often have to order them special, takes time. But for those really complex infections near the kidney arteries, they're often considered the best option if you can get one. Survival rates have been pretty good.
What are the potential problems with them?
You can still have complications, bleeding, where they're sewn in, the graft can clot off, or pseudoaneurysms can form later. They seem to have a higher failure rate if there's already an aortoenteric fistula, a connection to the bowel. But some studies suggest maybe less overall sickness compared to other methods.
Okay, what about the antibiotic-soaked Dacron grafts? Are they as good?
Well, regular Dacron in an infected field is risky, maybe up to a 20% reinfection rate. Soaking them in antibiotics, usually rifampin bound with collagen or something, helps a lot. They're used often, especially in emergencies when you can't wait for an allograft or for those big thoracoabdominal repairs.
Does it work?
The results are a bit mixed in the literature. Some studies show pretty high rates of complications or reinfection, like 4 to 22% reinfection in one review. But other series, like from the Mayo Clinic, reported basically no late graft infections, though the initial surgery still had a significant mortality rate, around 20%. Another Mayo study looking at using them for graft bowel fistulas showed good long-term survival, but still some late problems. Silver-coated grafts are another option sometimes used.
Are there bugs they don't work well against?
There's definitely concern about using them with active MRSA infections. Some animal studies also suggest the antibiotic effect might wear off after a week or so some surgeons might limit them to maybe less aggressive, lower virulence infections.
Okay, now this NAIS procedure, using the patient's leg vein to rebuild the aorta, that sounds wild.
It is a big operation.
Yeah.
NAIS stands for neo-aortoiliac system. You harvest the main deep veins from the legs, the femoral and popliteal veins, and basically stitch them together side by side to create a new tube to replace the infected aorta and iliac arteries.
Using veins as arteries.
Essentially, yes.
No.
It was first described by Clagett. It's a long surgery, takes a lot of time, so it might not be great for really unstable patients or the very elderly.
Yeah.
But the huge advantage is you're using the patient's own tissue.
Which means?
It's very resistant to getting reinfected, less than 2% reinfection usually reported. And the size match is often pretty good.
Yeah.
Patency rates, how well blood flows through it long term, are generally excellent. Mortality rates are relatively low, often under 10%, but it's still a major operation with potential morbidity.
Like what kind of problems?
Well, harvesting those big leg veins can cause significant leg swelling afterwards, sometimes needing a fasciotomy to relieve pressure in the muscle compartments. And patients can have some mild chronic leg swelling or venous issues long term. Graft narrowing, stenosis, is rare but can happen, so they need regular ultrasound monitoring.
So, 3 main in situ options: allograft, soaked Dacron, NAIS vein graft. What about bypassing the whole area extra anatomic reconstruction?
Right. The main extra anatomic option for the abdominal aorta is an axillary bifemoral bypass. A graft is run under the skin from an artery under the collarbone, the axillary artery, down to both femoral arteries in the groin.
So blood flow completely avoids the abdomen.
Exactly. Then, usually in a second stage, the surgeon goes in and removes or at least closes off the infected aortic aneurysm. The closure of that aortic stump can be tricky and needs to be done really well to prevent it blowing out later.
Is this safer than operating directly on the aorta?
It might seem less invasive, but it still carries significant risks. Managing the infected aorta is still necessary, and complications like aortic stump rupture can happen later. The bypass graft itself can get infected, which creates a huge problem. Long-term patency of the AXFEM graft is okay, but maybe not quite as good as aortic grafts. Interestingly, recent studies suggest long-term survival might actually be similar between extra-anatomic and in situ repairs in comparable patients. It's often reserved for specific situations now.
And finally, what about endovascular repair, EVAR, using stent grafts for these infected aortic aneurysms?
EVAR is definitely being used more, but its role in active infection is still really debated. It's tempting because it's less invasive up front.
But does it work? Does it cure the infection?
That's the big question. Stent grafts can seal off the aneurysm, but they don't remove the infected tissue. Certain things predict bad outcomes with EVAR for infection, like if the aneurysm is already ruptured, or if the patient has a fever during the procedure. That suggests ongoing infection is likely.
What kind of bad outcomes?
Persistent sepsis, needing more procedures, rebleeding around the graft. Some studies show short to medium-term survival, maybe similar to open surgery at 2 years in some analyses, but it seems very dependent on the bug.
Like salmonella or MRSA?
Exactly. Salmonella infections treated with EVAR tend to do poorly. One study reported no survivors at 1 year among patients with MRSA aortic infections treated with EVAR. And if there's already an aorta enteric fistula, EVAR outcomes are much worse. Plus, if you do need to convert an infected EVAR to open surgery later, that operation is often much harder.
So where does EVAR fit in?
Right now, probably the best role for EVAR in infected aortic aneurysms is as a temporary measure, a bridge. You put the stent graft in to stabilize a very sick patient, control bleeding perhaps, let them recover a bit, treat the infection with antibiotics, and then plan for a definitive open surgical repair later, removing the infected aorta and the stent graft.
Okay, it's not a really thorough look at the aorta. What about infected aneurysms elsewhere, like the legs, arms, neck?
Yeah, they happen, though less often than aortic ones. Down in the leg, the femoral artery in the groin is common, often related to IV drug use or those artery access procedures we talked about. MRSA is a frequent culprit there.
How do those present?
Usually pain, a lump, redness, swelling in the groin. Treatment is debridement, cleaning it all out, and reconstruction, often with vein or allograft. Sometimes, especially with really bad drug-related infections, they might have to just tie off the artery, ligate it, but that risks losing the leg if collateral circulation isn't good enough.
What about behind the knee, the popliteal artery?
Popliteal infections are pretty rare, often linked to endocarditis spreading or bugs like strep and salmonella. Presentation is pain, swelling, maybe signs the foot isn't getting enough blood. Treatment is similar to debridement and bypass, usually with vein.
And the neck arteries, the carotids.
Carotid infections are really rare now, thankfully. Used to be more common from things like throat infections spreading. Now, usually it's septic emboli from the heart. It can cause fever, neck mass, stroke symptoms. Treatment is tricky because ligating the carotid has a high stroke risk. Sometimes reconstruction with vein is possible, maybe even covered stents in select cases, but it's complex.
Arms and hands.
Upper extremity infections, usually from trauma, catheters, or IV drug use again. In the forearm, the radial or ulnar arteries can often just be tied off because there's good backup circulation. But the brachial artery higher up usually needs repair to save the arm function.
And finally, the arteries supplying the gut. Visceral arteries.
Yeah, those can get infected too, often from septic emboli or drug use. The SMA, superior mesenteric artery, is the most common site. Rupture is a big risk. Treatment often involves removing the infected segment. Whether you need to reconstruct depends on collateral flow to the intestines. Ligation is sometimes possible. Wow. This has been incredibly comprehensive. A really deep look at a scary and complicated problem. If we had to boil it down, what are the absolute key things you want people listening to take away? I think the main points are: 1. Infected arterial aneurysms are serious, potentially deadly conditions. 2. They're diverse, different causes, different locations, different bugs. 3. Diagnosis relies heavily on good imaging, especially CTA. and needs a high index of suspicion. And 4, treatment absolutely requires both aggressive surgery removing the infection source and prolonged targeted antibiotic therapy. Early action is critical.
It really drives home how complex vascular health can be, way beyond just cholesterol and blockages.
It really does. And maybe a final thought for you to chew on. We talked about risk factors like immunosuppression and drug use increasing.
Mm.
So how might this landscape of infected aneurysms continue to change? Are we going to see different patterns, different bugs becoming more common? What new challenges will that bring for preventing and treating these infections down the road?
Yeah, that's definitely something to think about, a constantly evolving threat.